very much.
And I'm actually looking forward to coming back when I can spend a whole day on campus and see some of the demos of things that people are doing. And in fact, think of this talk today as a whirlwind tour of a bunch of different topics. I could spend 3 hours on one of the pilots that I'm going to show you, and I've decided I'm just going to give you a glimpse of a bunch of different things that we're doing as an opportunity to seed future conversations when we can actually spend more time doing that. So I called this disruptive technology for the perfect storm, Intel's R&D for the age wave. The other thing I should mention is we do a lot of R&D that has nothing to do with aging, with all the other parts of healthcare, electronic health records, major studies of nurse workflow worldwide. I'm not going to talk about any of that today. I'm really going to focus on aging and particularly independent living and how we develop platforms for the home. And I'd be happy to come back and talk about those other issues. Now, we all know why I'm really here. I'm here to talk about the #1 global human challenge. And, of course, you all know what that is, right? There it is. The blinking VCR, right? How do we solve that problem? That's why we're all here today. I mean, actually, if you think about it, I think my industry, I think the computing, communications, and consumer electronics industry think this is the #1 global human challenge, right? So it's, I'm going to make sure the VCR never blinks and the remote control will automatically configure itself wirelessly. Woohoo! And I'm kind of like, why don't we take that energy and think about, how do we develop technologies that say that whatever device mom is near her prompts her to take her 9 medications safely? Or, my industry is kind of like, you can turn on the heat or the air conditioner via an internet browser from anywhere that you want to be. And while that might be convenient, I'm not so sure it's a pressing human condition problem that we need to focus on. Why don't we use that infrastructure to monitor a frail father's safety, even detect and prevent falls before they happen in the first place? Or, you go to the Consumer Electronics Show and it's all about download any Hollywood movie, never a late fee, right? Another burning human pressing question that we've got to solve and spend hundreds of billions of dollars on. Or maybe we ought to use that infrastructure to stream a multimedia coach to my mom to help her do physical therapy. So I'm not saying that we should stop doing digital entertainment, but I'm saying there's some pressing issues in the world. And the good news is all of this gear that's coming into our lives from digital entertainment offers us a platform to do health and wellness and independent living in some new and different ways. So it's actually great that there's a whole other industry bringing the cost of these technologies down, driving standards that we can then leverage to do health and wellness differently. And I'll show you some examples that we're trying to pilot of that today. Focusing on independent living has been a kind of personal passion and mission and quite frankly, need of mine for a long time. When I was 16, I was a caregiver for my grandmother with Alzheimer's, so much so that I didn't have time to get my driver's license until I turned 18. And, you take a young guy who's a teenager and don't give him that rite of passage because he's so swamped dealing with how Alzheimer's has impacted the family. That kind of leaves an impact that I still think about a lot. And I actually was on sabbatical from Intel this past summer. And on the one hand, I was lucky that I happened to be on sabbatical, but ended up dealing with moving my grandfather of 90 years, who's 95, who had lived in his home for 80 years, into a nursing home because of falls. And not a week after we did that, my wife's grandmother falling, breaking her pelvis, and through a series of medical errors, dying from simple medical errors of people forgetting to reconnect her oxygen and not noticing on the chart that she was allergic to Tylenol and giving her Tylenol that she then broke out, and it led to bed sores and infections. So when I say this is a personal need, I mean, I'm Eric Dishman. I work at Intel. I run a national not-for-profit. I have good friends with 200 of the most important CEOs in long-term care, and I can talk and call 20 senators, and I have money and means and education, and I can't stop this, right? And if I, with all those means at my disposal, can't stop these ridiculous things from happening, what happens when you don't have all those resources available to you? And it was a very sort of frightening and sobering wake-up call to me to come back from sabbatical and say, I wasn't so much relaxed, but sort of pissed off at our healthcare system and saying, we've got to do something. This healthcare paradigm of crisis-driven care can't scale. This was actually work that I did in 1992 when I worked for Paul Allen, where we were really thinking about how do you use information and communication technologies to build a better nursing home. So we built these sets out of cardboard walls and this kind of nurses station that let you sort of track the patients and the other nurses so you could try to manage workflow better with some wireless technologies. Had a wireless earbud system that let you kind of communicate like the Vocera system that's on the market now. It was wireless and it worked really well as long as you wore this backpack with a bunch of technology in it, which may have led to heart attacks and cancer for all I know at that particular point in time. And the interesting thing about this project is we kind of asked the wrong question. It wasn't how do you use technology to build a better nursing home, but actually how do you use technology to get rid of the notion of a nursing home? And how do you put technology into the place that people want to call home to help support them staying in that environment? And in many ways, since 1992, that's been kind of the question. That's been kind of my life mission. And that's what I've been lucky enough to get Intel to sort of pay some attention to. And I'll show you some examples of that. So I said, this is about a perfect storm. I'll go quickly through this because many of you in the room know this. Many of you in CITRIS have already been focusing on aging issues, though some of you who were asking what is CITRIS today, it's clear we have a mixed audience here. So, I think of this as a disruptive demography. This was in 2002, the percentage of people over the age of 60 around the whole planet. What you see is a lot of green and yellow, so about 0 to 9% or 10 to 19%, with the exception of Western Europe, where you see a lot of orange already, right? 20 to 24% of the population already over the age of 60. And, simply put, there are about 600 million people over the age of 60 in the year 2000 or so. Those numbers are going to double to 1.2 billion in another 16 years, and then almost double again to more than 2 billion by 2050. Now, this is a real challenge because we can't pay for health care now, right? So how are we going to sort of double or triple in many nations the number of older people coming through the system who tend to be the lion's share of health care costs? How do we deliver quality of care to that many people while reducing costs? That's a real conundrum. And business as usual, health care as usual, is not going to scale to that population. Here's what it looks like in 2050. United States at sort of 25 to 29% over the age of 60. Much of Western Europe over 30% at that point. With the exception of sort of Africa, even South America and many of those countries at 20 to 24%. This is not something any industry can ignore. Right? I mean, certainly this is a market opportunity, and all the work you're about to see from Intel is funded by the business group, not the charitable foundation. This is a business opportunity to think about this disruption. But it is also a business threat for any company to actually be successful while having a workforce, half of whom to up to 3/4 of whom are going to be doing part-time care for an aging parent. So it's both issues. It's both a threat and an opportunity to think about as we go forward. So what are the pieces of that? That disruptive demography is part of it, right? It's not only the doubling of the number of seniors and the number of people coming through, but it's also the number of people in the workforce doing part-time care. 2/3 estimated by 2025 in the United States doing 20 hours a week or more of care, mostly for an aging parent. Shortage of care professionals, right? We could 10x the number of physicians and nurses, which is not going to happen. There's no scenario in which that's going to happen. And we would not have enough sort of professional caregivers at the rate things are going to actually care for the population that's coming. It's also the disruptive economics of this. Predicted to be, the latest figures in the United States is that we're predicted to be $4 trillion is the healthcare budget in the U.S. in 8 more years, 20% of the GDP. That's the latest from CMS. It's not only the cost of healthcare, but it's the lack of pensions, it's the lack of insurance, it's the lack of savings that are going on. Not just in the United States, but in many parts of the world, particularly in the U.S., though. I mean, 8 of the Fortune 20 companies getting rid of their pensions over the last 2 or 3 years, and more of those expected to come. So that's a real big challenge. And then disruptive technology, a range of these, many of which you are working on in CITRIS, on Berkeley, on many of the California schools that are around here, wearable and wireless sensor networks, Web 2.0 capabilities, MySpace, YouTube, all these infrastructures that primarily teenagers and younger people are using are materials that we can use to sort of think about and reinvent healthcare as we move it forward. And certainly from an Intel perspective, powerful, affordable microprocessors. Affordable is one of those words that we're supposed to use instead of saying cheap. But lots of MIPS, lots of computing power in lots of different form factors that allow you to do things that we hadn't really thought about before. So arguably those things are coming together to say new models of care are going to be forced to emerge. Right? It's not really an opportunity. It's not really an option. I think all the things I'm going to talk about today are going to happen. What players and what industries are going to come together and what nations will lead the charge to develop this new marketplace is an open question. But I think there's a certain amount of inevitability of these kinds of things coming to pass. So the big question is, how do we prepare for the storm? How do we as citizens, as individuals who are going to have to be doing caregiving, we as universities who need to teach a workforce or teach a future generation of people how to deal with this, how do we as companies look at both the market opportunity and the market threat to us as we go forward? I can't answer all those questions in an hour, but I think those are the big questions that we need to wrangle with. So I'm going to give you an overview of how Intel's Digital Health Group is kind of preparing for the storm. I'll give you a kind of quick introduction about the group and then say, here's some of the areas that we're actually looking at. one of the things that we've done is reorganize the whole company about 2 years ago into what's called platforms. So if you think about those of you who know Intel's history, 1.0 was when we were a memory company. And it was a radical shift as Andy Grove moved the company to 2.0, which was really focused on microprocessors. Many who said this is absolutely crazy. It's going to kill Intel. You should never move to microprocessors. Memory is your core business, right? Well, thank God we did, right? The PC revolution, the multimedia revolution, the internet revolution was a really powerful force, and the company reformed itself. Now we're in the midst of sort of looking at broader platforms, right? If you think about what we did with Centrino and wireless laptops, it wasn't just the microprocessor, it was the microprocessor with other capabilities that made mobility and the sort of surfing from the sofa experience a reality, and the merging of media start to happen across platforms. And digital health is the newest and smallest business group reporting into the CEO of the company and is looked as one of the growth opportunities as we move forward in time. And we're not only interested in microprocessors, right? We're much more interested in software, services, peripherals, and all the things that go to sort of build an ecosystem around healthcare. This is how we're set up. Healthcare IT is one of the vertical businesses. That's sort of institutional PCs, servers, laptops, wireless security, all of those kinds of capabilities into sort of the healthcare enterprise, into the healthcare mainframe, if you will, traditional hospitals, clinics, that environment, small physician practices. Then our other businesses really focused on the kind of disruption, personal health platforms, those that are going to go into non-institutional settings, the wearable body area networks, the home platforms for chronic disease management, all of those kinds of things. It's just an emerging market. I mean, the total installed base of these kinds of telehealth platforms worldwide is not even a remotely interesting number at this particular point in time. But the pent-up need for remote diagnostics and remote care and personalized care management is enormous. So we're trying to figure out how do you break that logjam and bring kind of volume economics that Intel can bring and standards to try to get that marketplace to take off. So two big pieces of this horizontally are standards in both of those domains, on the enterprise side and the home side, and also this kind of people-driven R&D process. And that's what I drive, and that's what I'm going to talk about mostly today, particularly within the context of aging. But I wanted to give you a little sense of other things that we do. And as I said, I'm happy to come back at some point and talk about the R&D that we're doing to look at nurse workflow and physician workflow and electronic health records and all of that in the enterprise side of things. But that's another conversation. I'll just mention 3 standards activities, really kind of 2, that are focused more on the independent living and home side of things that you may have heard about. The first is called the Continua Health Alliance, which is a standards body that Intel created with about 20 other founders, big companies, Cisco and medical device manufacturers, consumer electronics. So all these kind of weird bedfellows coming together to try to, in advance of the marketplace, define standards so that these home health technologies are robust, reliable, and if you bought a chronic disease management system for your mom and then there's a better blood pressure cuff that comes along or a new ECG heart monitor, it's going to speak to whatever you buy, or if you upgrade, all of your old peripherals will work. So there's 100 companies now in Continua, big names that you would all know, and early next year you will start to see Continua logoed products. So if this product, this blood pressure cuff, this scale, this wireless thermometer, whatever it is, if it's logoed, you'll know it's built on a set of standards, and it should work with any vendor's PC or home health appliance or personal health system. Dacia is basically, this is Intel as a large employer, though we're not nearly as large as somebody like Walmart. So one of the key companies to help launch Dacia was Walmart. It is basically employer power collectively coming together to say, we think personal health records are good for people, right? We think people having access to their own personal health data and something that helps them manage and track their own health and wellness is a great thing. The problem is there's about 400 PHR vendors out there today already. Some of them selling software directly to consumers. Some of them selling little USB keychains that let you track your health and wellness and sort of take it with you where you want. Some of them selling web-based models. Some of them selling to your employer, so you receive this for free from your employer to help manage your chronic condition. And some that are coming from physicians groups. The reality is 400 of these companies are not going to survive. But what you don't want to do is spend all this time entering all of your historical data about your health care, getting all this stuff into there, and then your vendor goes out of business and you have to do all that all over again. And what you don't want to do is switch to a different employer who happens to use a different PHR and say, oh my God, all that old data is worthless. So Dacia is about getting critical mass of employers to say we want to drive some standards in personal health records and a not-for-profit trusted digital vault that can contain that data And you are the only one that can access it. Your employer can't access it. Your other people can't access it at this particular point in time. A lot of issues around privacy and security in this domain, but we believe if you don't drive standards and you don't drive sort of a third-party vault to sort of house that data, we're going to get into this really nasty paradigm where it's like people are going to be going out of business and PHRs will never take off as we go forward. I'm not going to cover the third item here right now. So on the R&D front, standards is just one of the things that we're doing. On the R&D front, which is really where I spend most of my time and focus, we have a very social scientific kind of people-driven perspective. I'm a social scientist by training. I'm not one of these Intel engineers who can rebuild a computer out of paper clips and gum wrappers and other kinds of things for you. So I barely understand what we talk about with core silicon. But in our group, we really study people across a range of environments. We try to understand what their problems are. We develop quick, rapid prototypes that try to embody a solution or what a solution might look like. We pilot these and field test these in environments from hospitals to homes. And then we try to turn some of those prototypes or some of those capabilities into new product directions for Intel. Simple example, not in the domain of aging, is a lot of work that we did on nurse workflow. Intel announced with a company called Motion Computing and then recently with Philips a new device targeted for nurses, really trying to, from the ground up, understand the unique needs of nurses who are largely ignored in the healthcare innovation space. They get the kind of hand-me-downs from physicians, but building a robust device that can be wiped clean, portable, has battery life, and all these kinds of issues solved to sort of help a nurse over their particular workflow do that. And all that was kind of driven from, let's go live and breathe the lives of nurses in the trenches of a range of domains before we actually go build this device. In the area of aging, we've done social science field work of living with people in more than 1,000 homes in about 100 clinical environments, 20 countries, and we got about 12 pilots going of independent living and personal health technologies, a few of which I'll show you today. And if I describe our group, it's kind of, everyone makes fun of me, but it's the kind of 3 E's. We're ethnographically driven, we're evidence-based, and we're ecosystem-oriented. And what I mean by that is ethnographically borrowing techniques from anthropology, have medical anthropologists, psychologists, sociologists on our staff who go and study people in real-world settings. We do large-scale surveys. Sure, we do focus groups. But this is really about taking the engineering teams into the field and bringing the field back and helping us understand what problems are. For example, before we launched the digital health group, I had a huge research lab of myself and one other engineer for the first 2 years of this project that helped launch the digital health group. And the two of us actually spent about a year studying 100 households dealing with Alzheimer's. And you'll see some of the Alzheimer's work that we did here today. And we do it across the continuum of care, in people's homes to continuing care retirement centers and all points in between. And we do it worldwide because cultural feelings about aging and what it means to be older are very, very different in different parts of the world. And you have to understand those unique nuances as you go there. Evidence-based, meaning you can't just do a focus group with some of these technologies and the people like it say, yeah, that helped prevent heart disease. You have to do evidence-based technology trials just like pharma does with drugs. And some of these trials that we're doing are going to take 2 to 5 years to prove their worth. That's a very different development cycle for our industry. Right? I mean, we know sort of chip and processor roadmaps 10 and 15 years in advance. But in terms of the applications and proving out that there's an ROI or an efficacy for the healthcare technology, this is clinical trial research in some cases. Not always. Some of the things that we're doing aren't FDA regulated. Some of the things we're doing could come to market very quickly. But you'll see some of the claims that we're trying to make about early detection and prevention. It's going to take longitudinal, large-scale trials to prove that. And I'll show you the seeds of some of those today. And then finally, in addition to being ethnographically driven, evidence-based, we're ecosystem-oriented. Intel is not a healthcare company. We have hired healthcare experts. Dr. Bernstein's here with me today, ER doctor on the clinical faculty at UCSF, other healthcare experts. But at the end of the day, we're not Kaiser, right? We're not Johnson & Johnson. We are not going to be those. We have to do an ecosystem approach. And at the end of the day, we're not going to have enough resources to actually fund the kind of large-scale clinical pilots that need to happen for independent living. So there's several activities that we're doing to try to stitch together collaborations amongst universities and industry to drive these kinds of pilots. And it's partly what I'm so interested in about CITRIS. You've already stitched together 4 universities and many others in the community here in California. How do we leverage that to build California out as a test bed for testing out these kinds of technologies with seniors and family members and professional caregivers across the state? The 2 that I'll sort of point you to here are the Center for Aging Services Technologies. That's my night job. That's my volunteer job where I volunteer to chair this not-for-profit. That's really our national organization to try to drive advocacy for technology for independent living. By and large, the U.S. government is missing in action on doing anything to prepare for the age wave. I kind of jokingly refer to this as Y2K plus 10. Right? With the Y2K challenge, you had government driving an industry-wide, cross-industry conversation with academics, bringing people together to try to say, oh my gosh, we've got a problem coming in the year 2000, and we need to change some things about technology infrastructure to get ready for it. Well, that tsunami, that demographic tsunami that's coming, is every bit as scheduled, right? 2011, 2010, that's when the first boomers start to reach official retirement age, and it's just going to get worse from there, right? This demographic tsunami is coming. We know what the economic impact is going to be if we can actually admit it to ourselves. And it's not that technology is the magic answer to all problems, but it certainly needs to be part of the equation as we try to invent and scale healthcare for the coming wave that's going. CAST is really about trying to drive government attention. If you go to agingtech.org, you can see all about CAST. I'm not going to show you the vision video right now. There's a vision video that we did for every member of Congress and for the president that's on there that really tries to encapsulate not the right answers about what technology can do, but the right questions about how technology can move care to the home. So I encourage you, it's free. Go to agingtech.org. It's free for academics to actually join CAST. And you'll see some legislation that I'll talk about in a little bit that I'm hoping you in the room can go and push Congress on to try to get our nation ready for this. The other I'll point out here is Trill. This is what we just launched in Ireland. A lot of the innovation in independent living and aging and personal health is not going on in the United States for a whole host of perverse reasons. And the interesting research and the interesting products are starting to come onto the market in Europe and Asia. So they know that that marketplace that I showed earlier on is a perfect storm of opportunity for them. And they're doing very progressive things from regulatory environments to investing in R&D to get their nations not only prepared to deal with their own aging population, but be a marketplace to other parts of the world. And Trill in Ireland, if you go to trillcenter.org, is really focused on 3 areas. Falls, which I know some of you in the room have done work on. Social health, so how do you help people who are often isolated and lonely and have cognitive problems stay socially active and stay socially healthy through information and communication technologies. And the third is really on cognitive assistance. Right? A lot of people going through a range of cognitive deficits, from full-blown Alzheimer's to mild cognitive impairment to deficits that occur from stroke. How can you help people live a quality everyday life using technologies dealing with those cognitive deficits as they go forward? The magic of Trill, which is what I would love to see CITRIS try to do in California and then the rest of the United States, is that there's kind of an open source hardware and software model. It's not literally open source, but that's the best metaphor I can use, where the participants are all contributing hardware components, software components, data, and knowledge to build a research platform together that's going to be far more scalable and far more usable than what any one university can do by itself. So by the end of or middle of next year, you'll hear the Trill 1.0 platform, which will take a bunch of stuff on falls, a bunch of stuff on social health, a bunch of stuff on cognitive assistance, an underlying infrastructure of wireless secure connectivity, an underlying infrastructure of wearable sensors and those kinds of things. Because the last thing in the world we want universities to be doing is spending all this time developing technologies that in many cases are already on the shelf. And we want them to focus on outcomes. We want them to focus on applications. We want them to focus on interventions and scale up these pilots from playing around with 12 households or a lab in our university to hundreds, if not thousands, of households testing these technologies out. Trill is the beginning of that, and I'd love to make connections between the academic community here and the academic community in Ireland and Greater Europe that Trill's involved in. All right, so what is Intel's approach to sort of saying how are we going to invest? So the first strategy of dealing with this perfect storm is what we call shift left. And quite simply, if you look at the cost of care per day on the bottom axis here, from $1 a day to up to $10,000 a day, just roughly, as sort of as a metaphor. You think about the intensive care unit. Very expensive, cost per day, really low quality of life, right? For the people who are working there and for the people who are having to be there for medical reasons, right? You don't want to be here. You don't really want to be at the hospital, bad place for infection. You don't really want to be in a skilled nursing facility. You want to be in the upper left-hand corner, living in your own home, quality of life, low cost of care at that particular point in time. Since we're not a big healthcare company like a Philips or a GE or a Siemens, we are choosing investments that help move technologies to the left in this continuum. Is there an investment that we could do, I'm going to make it up, that would help move MRI-like capabilities from these big megaplex machines to something that every primary care clinic could have as a diagnostic? How do we take diagnostics and capabilities that are in the clinical environment and move those to the home? Get the cost down, get the usage model, get the usability there. So all of our investments, from investment in companies as well as the investment in R&D, are kind of guided by this shift left strategy. The second is to say, invest in the other 80%. And all I mean here is, this is a great chart that Byrne found that basically looks at, for 1,000 people, for every 1,000 people in the United States, right, 800 of them report symptoms, 327 of them consider seeking medical care, like 14 of them receive home care, 8 are hospitalized, and in that little corner right down there on the bottom right, less than 1 person out of 1,000 is hospitalized in an academic medical center. Yet, the lion's share of investment in innovation in healthcare is driven by that little corner. Right? We study people in academic hospital centers, right? And that's where the locus of care is. Every time we do a keynote or a talk about home health care, the conversation inevitably turns back to, well, how do we make the doctor more efficient in the hospital? And I'm not saying that's not an interesting problem, but we're not going to get out of this demographic mess if we continue to focus on that little box, or that sort of 20%, which is, you know, have problem, take pill, or have problem, rush to the emergency room. That's the paradigm that we operationalize around now, and that's the paradigm that we innovate for. We need to focus innovation on that other 80%. Now, granted, we also have economic incentives that keep this 20% alive. Right? We have work that we've been doing that could possibly change the game in heart disease, and we've actually had lobbies who are interested in making sure that that doesn't happen, because hospitals make an enormous amount of money out of heart surgeries. In fact, that's their cash cow in many cases that are keeping them afloat. So we can't pretend that there aren't perverse incentives that kind of keep things focused and down the right-hand corner. Actually, this is kind of shift left as well, right? So I kind of like that as well. But nonetheless, from an R&D standpoint, from an innovation standpoint, we need to be thinking about that other 80%. And then finally, we need to invest in the whole caregiver network. Too many of the solutions, too many of the approaches are all about, how do I make the primary care doctor more efficient? Or how do I, not much at all focuses on the family and friend caregiver, who do the lion's share of care for seniors around the world. Or how does the senior themselves become more proactive about their health and wellness? We don't design infrastructure for making that community work well together. And if you start thinking about that network, that care network as the unit of analysis, we're going to change how we do things. You can use a lot of infrastructure that already exists, but that's the unit of analysis, that intersection, not the individuals within it. So this is the cast vision video. I'm not going to show it now. You can look at that at the agingtech.org site. I think it's been a good kind of imagination piece about what we're talking about. So let me give you some case studies that we're doing. And these are roughly in chronological order. I mentioned to you when my lab was that huge group of myself and one other engineer, and we did the Alzheimer's research. And we eventually grew to a lab of about 6 or 7 people and did this study of 100 households with Alzheimer's. And by the way, when we go study 100 households, we go study the rest of that care network. So while we study 100 households, we went with them to their clinician visits. If they had a daughter who was a part of their care network, we went and studied them. It's very difficult to budget for. Intel hates these studies because it's like, you have no idea. I don't know how many places we're going to have to go, right? You can kind of guess it. In one of the most interesting things in that study was that the experts who study Alzheimer's through a microscope and are doing amazing things with tissues and chemistries, but have never really actually gone and lived and understood, unless they've been through it themselves, what the Alzheimer's experience is like, were telling us that one of the reasons these people with early and moderate stages of dementia become really depressed and socially isolated is that they can't answer the phone anymore. They don't understand what the phone ringing means, or they don't understand what the doorbell ringing means. So we went out and actually lived with 100 households. This is Barbara from one of the studies. Barbara was in her 50s when she was diagnosed with Alzheimer's. This is her showing us her phone. She's afraid of not knowing who is on the other end of the line here. She knows what the phone ringing means. She knows that the phone rings. She'll walk over to it and then has to think about, God, am I going to be able to remember who this person is or not? Or am I going to embarrass myself by not knowing the difference between my daughter and my doctor who's calling? She's really, like many of the patients in our study, has gone into self-imposed exile due to this embarrassment about her memory loss and not knowing that kind of name lookup table. and not in her case, but in many of the others, they had clinically diagnosed depression, which many neurologists will tell you actually accelerates the advancement of the Alzheimer's. So it's actually a biological effect because of the depression. I'm not an expert on it. I don't know. And her husband says she lost herself and she lost her social network, right? Just everything sort of started to fall apart at that particular point in time. In fact, this is Barbara. There were friends coming over. Her husband puts up pictures of people who are going to be coming over that week to try to get her kind of face flashcards. Right? These are names and faces of people that we're going to interact with so she can be prepared and try as best she can to prepare for them coming over. So in this particular first study, there were 100 things that we could do that we could sort of focus on with Alzheimer's. But we said, how can we measure social health and changes in social health? The other interesting thing about the study was about half of the respondents, when we asked them to go back, the family members and friends of the person with Alzheimer's, told us that one of the first things that they remembered when they thought something might be wrong with this person were two things. Their laughter changed, and they had trouble with the openings of phone calls. Right? Well before they were diagnosed, well before they knew any problem. Now this is self-report and retrospective, right? So we don't know that much about it. But we believe that it is actually changes in your relationship that manifest in how you laugh with a loved one, right? If you think about laugh, it's highly structured, right? My wife still laughs at my jokes, and that's one of the ways that I know she loves me, right? But that timing of even laughter could have significant impact to sort of show you're having a cognitive problem. You're not getting the joke. You're not getting the relational gist with the person. And the opening of phone calls, where you're doing that negotiation to figure out, is this somebody I already know, right? If the phone is, if I pick up the phone and I say hello, and the person on the other end recognizes my voice from that quick hello and just says, hey, Eric, and starts talking, I'm supposed to know immediately who that is. They don't even self-identify. That's one of the ways that we show that we're close to one another. If that mechanism starts to break down, then that's an indicator something may not be right here. So we're doing two things with this study. We've put infrastructure in place that's measuring and monitoring the amount of social interaction people are having. Phone calls, email if they do it, in and out, visits from other people, right? And we're just trying to develop this social health index that says, here's my normal amount of social interaction. Do I have peaks and declines or something that are measurably meaningful in a medical way? I won't know for another 3 years. We did this as an initial pilot. We just got an NIA Roybal Center grant with Oregon Health and Science University, and we're putting these capabilities into 300 homes of healthy 80-year-olds who over the next 3 years, half of whom will end up having some form of diagnosed dementia. And we'll go back and look. Did the sensors that were collecting pattern data around the home mean something? Did the sensors that were collecting social health data mean something that help us do early detection? That's a hard, long scientific journey that we've got to go down. In the meantime, all of that infrastructure that we put in place made the quality of life for the people involved much better. We built a device that was simply caller ID on steroids. It was a screen next to their landline phone. This is kind of an old, I've got to get the new screenshot of the newer version. And all it did was say, this is Kevin, he's your friend, and your last conversation with him was about sailing your trip, the sailing trip that you're going to take next summer. So it would just give them a little bit of context about key people in their social network about who this was. Barbara's face cards and an electronic form that gets updated with some data that's going through. The way that we did this, we could have done speech recognition. We could have done topic gisting. We said there's privacy issues. It's complicated to get all this stuff to work in real people's homes, right, where there's stucco in Las Vegas and all these wireless sensor networks fail because you're living in a Faraday cage, or where you're installing these in Ireland where these are 250-year-old homes with 30-foot thick stone walls, right? You got to do different things in different countries, and it's a real different experience to go put these things in real environments. So they kept a quick conversation journal on both ends of the phone call, right? I take a few notes about what we talked about. My mom takes a few notes about what we talked about. We thought nobody would do this. But the more you put into it, the better quality of conversation that you have the next time. So what typically would happen in this, a lot of these people with dementia would call their boomer child who was working a 15-hour day. They'd call it 8, they'd call it 9, they'd call it 10, they'd call it 11, they'd call it 12. And the system would say, you've already called your son 8 times today. Do you know that? Oh, no, I didn't remember that. And so suddenly you've got this kind of queuing that says, oh, okay, I didn't realize I had done that. And the conversation journal, the more you put in there, the better quality of conversation you would have. What we would notice when we observed phone calls between people before this was the boomers would get so frustrated because it was a repeat of everything that had happened that they're just exasperated and pissed off and want to get off the call as soon as possible. So really trying to help sort of navigate as that goes through. Elegantly simple applications. And then last was the social health display. One of the people called this the inheritance detection system, because basically what this did was it showed the people that mom was interacting with frequently close in, and the people that she was losing contact with out. So the good children who get the inheritance are right here close into mom, and the bad children are way out here on the edge. Now, you laugh, but it's like, I mean, that shows some of the privacy issues and those kinds of things that occur when you actually put these systems in place, and how people will use them to make decisions about their relationships. But what typically happened is the people would look and see, oh, this is my friend. He's my best friend. Why is he way out here on the edge? They would leave themselves sticky notes and other kinds of things to say, I need to call so-and-so, or I need to invite so-and-so out to lunch. And over the course of a week, they had a reflection of the progress that they were making of regaining their social connection with other people. Now, the other thing that this did, the boomer age caregivers, after the first month of the trial, would call us and say, your system's not working. And we're like, well, why? Well, no one called my mom this week. And we had all these redundant systems in place. And it's like, no one called your mom this week. And for us boomer age people who are out there working our ass off all the time and have a cell phone stitched to the side of our face, and we are socially saturated, right? We can't imagine that this loved one who we interact with is sitting there and a week's going by and no human being has visited and no one has called. So the other effect of this mindfulness about the social interaction is that on the other end, if they care, they can start to say, oh my God, I had no idea. I'm going to start calling mom. I'm going to start visiting more often. These were some simple technologies, mostly off the shelf. The early detection problem's a long, hard scientific problem. The help live quality of life sooner, there were a lot of sort of low-hanging fruit opportunities to focus on independent living for that. Second example, Parkinson's disease. Again, about a study of about 50 households dealing with Parkinson's. These were people already diagnosed with Parkinson's. In the case of Parkinson's, there aren't that many people with Parkinson's, but there's a lot of capabilities that if we could help with Parkinson's, might help with stroke and a lot of other conditions as well. And one of the things we observed with people with Parkinson's when they went in for their visit with their doctor is they could, in many cases, control their tremor or walk fairly naturally for the 15 minutes they were going to spend with their physician every 6 months. And then they're coming into this exam, and their physician's going to do some tests that are supposed to be objective, but are quite frankly very, very subjective, and then change their meds based on sort of what they see for that once every 6 month, once every 12-month window of opportunity. I mean, it was unbelievable, because we had tests of these people all the time, and then sort of what the doctor's assessment would be after you found the parking space and got there, and your blood pressure's up and all of that, and performance anxiety of being normal in front of the doctor. All of those things sort of come into being. So the state of the art in sort of tracking disease progression for Parkinson's is pretty crazy. This is Carl from our study, 86. Parkinson's took several years to diagnose. He got juggled around from doctor to doctor. It took 3 years to try to kind of figure out what was wrong with him. His presented as weak voice, but that came after the problems were shoulder problems, right? He actually went in for shoulder pain and shoulder stiffness, but actually in retrospect, it was the kind of beginnings of Parkinson's. His wife says we did all we could to keep him off the pills, in this case levodopa, but eventually he had to take them, and he's never been himself since. Levodopa can have some nasty side effects, and it sort of gets worse every time. You have to take more of it to try to control your tremors. His identity is about making things. He's in his shop. This is his wood shop. This is a saw. He makes carpentry items and other kinds of things, and his wife literally sits on the other side of the door, terrified that he's going to hurt himself. But if you take that away from him, the essence of his life is kind of gone, right? I mean, he literally has a purpose jar that people come in and put projects that they want him to do for woodworking, and if there's nothing in his purpose jar, he has no sense of purpose, right? That's a hard problem to do. She literally sits on the other side of the door sort of in constant fear. So how do we, for somebody like Carl, assess the condition? And there's one path of research that we're doing that's looking at everything from, actually Carl did do email. His wife had to boot up the computer for him, but he would actually do email. Looking at keystroke occurrences, right? This is actually the difference between instant messaging and email, right? Your keystroke profile. A lot of these people are using remote controls to interact with television, so we started collecting button pushes for remote controls and looking at changes of pattern. Now, maybe all this is going to show is that he's getting arthritis. It's not going to tell us anything about his tremor, but it can be an indicator that something's up and we actually need it to get checked out. And the most interesting is work that we've been doing with Oregon Health and Science University on using solitaire and other games, which, my God, all of these people were actually playing if they had PCs. And looking over the course of 3 or 4 months, here's the number of moves as taking them to sort of win games as they're doing it, because you have a solver that knows how hard each game is. Or here's the number of lost games. Maybe that in and of itself doesn't tell you something, but that data partnered with data that says you're getting less physical activity moving around the home, and by the way, you've dropped off the scale for your social index, those threads start to come together to tell you something of nuance. But the more near-term thing that we're doing is we collected 5 or 6 standardized tests for Parkinson's and integrated them into one device where this could be tested at the home a couple of times a week. So we're moving data capture from a nurse with a stopwatch with variable size pegs from one clinic to the next doing a pegboard test to a standardized set of pegs, looking at the nuance of all the tests that happen in here, and they could test multiple times a week to collect this data and see what their personal trend is. So in this case, they do a finger tapping test on these 2 keys in the front. How quickly can you go back and forth between these keys? They go back and forth between these 2 arcade Pac-Man type buttons as quickly as they can, and it's also a reaction time test. When it beeps, you move to the other button. Classic Purdue pegboard test that's been done, I believe, since the 1950s or 60s, but actually looking at much more nuance of not only how long did it take them to move the pegs back and forth, but how much difficulty did they have putting each peg in the hole. And then 2 speech tests. They put on a headset, and they go, ah, for as loud and as long as they can. It's called the ah test. Great name. And then the other was the random pictures show on the screen, and the person tells a 1.5-minute story about what the picture is. And basically, we're looking at 2 things there. The amount of energy in their voice and what's called fundamental frequency variability, what roughly is a sort of measure of the amount of monotone, or sort of the range that they sort of have in their voice. We believe with many people with Parkinson's, you could actually detect it 8 to 10 years earlier by looking at changes in voice first. Because for many of them, the vocal tract and the vocal mechanism is the first muscle that starts to fail, not physical tremor that manifests itself. Don't know that, but that's speculation, and we're working on cell phone models of that to go test that out. But in the near term, and the other is a watch that they wear, measuring their tremor all of the time and uploading that data. So you can start to look at trends of saying, is my tremor worse in the morning? Is it worse in the evenings? Does it seem worse when I've taken pain medications? Or those kinds of things, and start to looking for those correlations. The initial phase is a 60-household study with 5 clinics, including Rush Presbyterian in Chicago and Dr. Christopher Getz, who is kind of the keeper of the Universal Parkinson's Disease Rating Scale, the objective measures for Parkinson's in the United States. The trial's going quite well. The next version of this will actually start to look at drug titration. So now, based on how I'm doing, do I actually need to take my full doses of levodopa? Am I having a good week? And that kind of thing. That's going to be a much more difficult trial to get off the ground in terms of human subjects, but that's where we're headed next. So again, that sort of same theme of collecting personal trend information. Now, the problem with that is that it's still a test that you have to sit down and take. So you still get some of that test problem, right? I'm consciously trying to do as well as I can in my test. By the way, we don't know if that device has a therapeutic impact or not. Does it help improve them if they practice like crazy? That's another trial that we're actually setting up to do. But you can see it, or sort of see the notion of personal trends, personal benchmarks, and shifting left so that capability can occur more frequently in a home environment, not just in a hospital environment or in a clinical environment. All right, where am I on time? I'll probably got time to do 1 or 2 more. We've just finished a pilot called CAMP. Not to be camp about it, but that stands for Context-Aware Medication Prompting. Here's various statistics about the problems of medication, and there's many more. Long story short, most of the people in our studies of people over the age of 65 were taking at least 5 meds, and many of them taking 8 to 9 medications a day. I have a lot of kidney problems myself, and I take about 8 to 9 medications a day, and I'm 39 and fairly cognitively healthy, just overly stressed. And I can tell you it's very difficult for me to actually manage that. So you throw in some cognitive decline and other issues, or physical dexterity problems, or can't read the label, then life gets to be very difficult on meds. We went and studied, I don't remember how many it was, but roughly, we typically do between 50 and 100 households of seniors who were actually trying to deal with their meds. Many of them had a range of technologies. They were using these pill caddy dispensers. Some of them were receiving these blister packs that arrive in the mail with all of your pills lined up. By and large, long story short, none of those systems work. Because the way that people manage their meds, by and large in their lives, is through a context-based prompting paradigm, not a time-based prompting paradigm. The people who were given a watch that alarmed or a station in their house that alarmed got really pissed off when it alarmed anyway, even though they had already taken their meds. Or they got really pissed off when it went off and there was somebody else sitting there who they did not want to know they were having a difficult time taking their medications on their own. Right? There's social stigma and embarrassment issues with this as well. The vast majority of the people who get the blister packs rip them open and go put the pills in physical places so they can have context, place-based reminders, not just time-based reminders of when they actually need to take that pill. So all of these systems that are out there, and there are hundreds of them, we have never seen any of them work effectively for helping to take people to take their meds in the right time. I don't think we have the right answer. I think we have the beginning pieces of it. Philip from our study, age 73, takes 11 meds a day, has diabetes, heart disease, asthma. None of my doctors has any idea of what each of them has put me on. Classic problem. His pharmacist knows better than anybody else. Wife recently passed away from depression and loss. She had been his meds keeper, and now daughters and people are trying to help from a distance to help him do that. Had been hospitalized twice over the past 3 years for medication side effects and interactions because he did the wrong things. And his daughter Mary's leaving these sticky notes. Here's one from, there's some of the vitamins that they're trying to work out for him as well. Here's Mary's sticky note. Right? Dad, call Mary if you have problems or bad dreams or diarrhea from your new medicine. Of course, how old this note is and which one it's referring to anymore, God only knows, right? But this is what people do to try to cope with that difficult reality. And by the way, the inability to medicate is one of the top 4 issues that lead people to shift right, to be put into an institution, not be able to manage their own health and wellness at home. So in this case, all we did was take simple sensors, a simple sensor medication cavity that knows you'd open the Monday through Sunday. Now, we have tagged pill bottles. That was much more difficult to work well and easy, so for this particular trial, we didn't use them. So even our system is still doing a bad thing. It's centralizing all those pills in one place, which I've already told you doesn't work for most people's mental models of distributing pills contextually in their environment. But it was a necessary evil for this stage of the study. The essence of the study was trying to look at context-based prompting on multiple platforms. On a watch, if that's what you preferred, your television interrupting you in a TiVo-like way, saying it's time to take your meds, a phone call, either on your cell phone or your landline phone, and these sort of audio prompts. Ignore this last right, we didn't do the voice badge. An audio prompt that you could put in multiple rooms of the house and then just say, hey, it's time to take your meds. And quite simply, there were other sensors that let us know you're about to leave the house, you're in bed, not a good time to bug you unless it's really urgent that you take this med. You've got other people in front of you. I might want to be more discreet and call you as opposed to interrupting your television show. And it did a few other things. If it looked like you were about to go out the front door, based on the simple motion sensors, then the system would guess that might be a good time to prompt you to take your med now. So the alarm is going to go off an hour later when you're driving your car, right? Because it's a time-based alarm. The context-based prompter is guessing that it's time for you to go out and you're about to go out for the day. It's okay if you take your medication an hour early. It'd be better than forgetting to take it while you're driving your car around. Simple context-based prompting. Still analyzing the data from this. Small, 20 households, I believe, that we did on this. Very, very small, right? There's only so much that we're going to be able to sort of claim about this. But I can tell you anecdotally, in terms of the directions that we're going, in general, context-based prompting seemed to work quite well for folks. And the challenge of this in particular is that different usage models occur between different households. Some would only use the television. Some would only use the phone. Some love to use the audio prompter and the watch. So what was the stimulus that made a difference from a behavioral, analytic, clinical trial design kind of way? Don't really know. So to really understand this, you're going to have to do this with large numbers of households and then retroactively look back and say, what were the different behavioral paradigms used and sort of what worked? What was the stimulus? What was magic? And incidentally, there are issues in here about, the audio prompt. Is it a beep? Is it the voice of your pharmacist? Is it a computerized Sam-like voice going, take your meds? Or is it the voice of Oprah saying, hey, it's time to take your meds? Those kinds of nuances make differences. And we weren't able to tease all of those out in a small study like that. But there's an enormous amount of research just to try to improve the meds prompting experience. All right, I'm going to pop to one last one. I won't cover falls, even though many of you are doing that. And I won't cover the heart monitoring cell phone. I knew I'd run out of time because I never know what I'm going to get excited about and talk about here. Come on, PowerPoint, catch up with me. So the last one I'll show you is just a simple example of another example of how simple technologies can potentially provide elegant solutions. Transportation challenges, particularly in Europe, where we're working with people where half of whom live in rural environments, but especially in the U.S. as well, where there's almost no public transportation available. You lose your car, it's like losing that social network. If you haven't had the experience of trying to take away the keys from an aging parent yet, it's one of the most unpleasant experiences you'll go through, both the conflict that you'll have and the impact that it has on their life afterwards. And they get cut off from the world because we're a car culture in the U.S. and they don't have that freedom, that independence anymore. So in Europe, here's what we're doing. We're using a WiMax tower in a small village in Ireland. This is Washington, D.C., so pretend I was going to explain WiMax. But WiMax is the next generation Wi-Fi. Think large coverage areas for Internet access, not just the size of a room or the size of a building. We're using a WiMax tower, and we're using some kind of capabilities like you have in social networking sites, YouTube, MySpace, and some GPS technology that's off the shelf. And this is actually data where we first, in this community, both in Dublin and outside of Dublin, tracked the seniors who still had cars. Where did they go? And what were their sort of normal routines, their everyday activities of daily living with their cars. And for other people and their social network who lived in their community, who they were willing to share that data with, we're just building this now and starting to test it, they can share that data with other seniors who are in their community who don't have cars. It's just ride sharing. But it's more than ride sharing, right? It's social health as well, because suddenly it's like, I can see that Bob goes to the market every Thursday. That's right by my sister's house. I had no idea, right? And so we were giving people these lightweight ways of seeing what each other's patterns are. And it's partly about ride sharing. It's partly about social networking. It's partly about giving them a sense of social purpose, or a sense of a purpose as they move forward. We'll see how this goes, right? Are we going to be able to show that we've reduced depression? I don't know. We may go that route. Or is it just so valuable that all the seniors in the community start doing it, and we want to just make it available as a widget that they can actually use whenever they like, right? So I think in all these cases, there's some long, hard technical research challenges, right? It'd be great to have one wearable wristwatch platform that knew your indoor location and outdoor location and didn't have all the problems with GPS. So there are still some hard technical problems in this. But there's some low-hanging fruit things that we can do now to start delivering value to people and figuring out whether there's a there in helping with social health and helping with purpose and helping with transportation. So let me close with just some final thoughts. As I think about CITRIS, and I think about the Berkeley campus, and I think about all of the energy and the intellect and the investment that's here, for one thing I'd say, focus some of it on aging, right? I mean, that goes without saying. You saw those demographics that are coming. We all kind of know it in the back of our heads, but very, very few of us are doing much to prepare for it. I think the degree to which you can help build a larger California visibility and advocacy for aging within the state and work with Intel and CAST and our not-for-profit, I think that would be a great thing. I have a feeling there's a bunch of stuff going on in California that we in this room don't know about. And step one really ought to be inventorying all of the aging kind of work that's going on in the state. We probably need to do some sort of demo day that highlights these capabilities to policymakers. The vision video that we did with CAST and for Congress and for the President was really just to grab their attention and say, it's not all about the hospital, right? There's a lot that we can do in the home. So using that, I can tell you that most policymakers don't have a clue what we're talking about. They don't even really understand telemedicine. And if they do, they have a very, 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 very narrow definition of telemedicine. So you've got to capture the imagination in some powerful ways. I would say build shareable research platforms. If every PhD student and every university holds all their secrets close to their chest and says, I've got the algorithm that's going to solve falls, and doesn't share that with others to build a platform that can be tested with thousands of households, we're doomed. This field is never going to take off. Because we can't afford, there's so little investment in this domain, we can't afford to take the investments that we do have and do redundant work, or not to build platforms that others can use to go fish for themselves. And that you'll see us in Trill and other places trying to build these research platforms. One of the challenges right now is that med schools can't go do any work in this domain unless they happen to have an engineering program there, because it takes so much systems integration and engineering to get this stuff to work. If we build these things robustly enough where med schools and others can go do it without having to have a cadre of 30 engineers involved, that's going to be positive. Then lastly, I'd say participate in national advocacy and make those international connections to Trill and other places. You could start very simply by going to the agingtech.org website, the not-for-profit that we work with. We introduced a Senate Bill 908 into the Senate last week, and the House bill is coming soon for the same bill. And this is basically the legislation. You can read it if you go to the site. You put in your zip code. It brings up the bill, and it brings up who your senators and congresspeople are, and it gives you a draft of a letter to say, please support this bill. And quite simply, all the bill does is say the President and Congress need to create a national consortium of 16 leaders from across industry and academia to start to put a plan together to get our nation's act together for the age wave and the role that technology can play. And from there, we would then proceed to deal with a lot of other policy issues as we go forward. So I'll close it there. I don't know if we've had time for questions or where we are, but
I think we have time for one question.
One question. All right, here it is.
So let's speak into the microphone because it is webcast.
I was fascinated by what you were saying, but basically you're talking about the end stage of chronic degenerative disease rather than evidence-based technologies that are already available. For example, I'll give you an example. Although you didn't discuss it, falls are one of the highest causes of morbidity in aging people. The parameters of vitamin D, which is essential to absorb calcium, which is essential for bone health, for neurological health, and for muscle health, have changed radically within the last year. The range of normal for 25-hydroxy vitamin D, which is the measure of the clinically useful vitamin D has literally changed from the range as of the middle of March 2006 has gone from 4 to 32, which was considered the normal range. The new range is 32 to 100. I do vitamin D levels on every patient that I see that comes into my office, and have been for many, many years. And I would say 80 to 90% of them are low in vitamin D. You put people on vitamin D, and you give them calcium, magnesium, their sensory motor system improves, their musculoskeletal system improves, the fall incidence decreases. It's very simple. I mean, everyone could be doing this. Other things, I'm just giving you a quick example. Yep. Any medical supply store have these hip guards. They're foam rubber hip guards. They cost a couple of bucks. You can't see them under your clothes. They literally reduce the morbidity from falls by 80%. I mean, these are the things that cost next to nothing that should be done, and these things should be done for people who have already suffered irreversible consequences. But for the people
completely agree. I mean, we're not surprisingly, we're an information and communication technology company, so those are the things we're focused on. Two projects I didn't show you were the falls, and another one focused on what we call mobile heart health. There we're going way, way back and saying, how do we just help people deal with negative affect, which is the seeds of a whole bunch of other sort of heart problems and a whole bunch of, in some cases, potentially even dementia problems. So in that case, we're looking at personalized therapeutic intervention on a cell phone to sort of help you do sort of exercises that keep you kind of moving into, this is with hyperaggressive disorder patients. I mean, I agree with you. We're looking for those kind of root causes that are way back. I would say about the hip technologies, and there's a range of assistive technologies that are out there. One of the big challenges is there's no channel for it that most people will go to. I mean, you go to big urban centers and there's, the medical durable equipment store that's often on a frightening side of where the part of town is, and it's often next to the porn store, quite frankly, right? I mean, we've done this. We've gone and looked at what the channel is. How do we move that stuff from this kind of stigmatized old people stuff to a sort of wider and pervasive channel, and how do you get that knowledge out there?
Doctors don't know about it, and the reason why they're not pushing foam rubber pads is because virtually there's no money in it.
Right.
The money is in the technology.
Right.
I mean, it's the same way that nobody is pushing vitamins and minerals and herbs. No, the fundamental research isn't being done because nobody can patent the technology.
Yeah. No, I agree.
If they could, you would be getting...
Well, and I would say to CITRIS and the groups that are here, the approach that we've taken with all of these, you've seen some ICT-related stuff because that's mostly what we talked about here. We've stepped back with all of these and held international workshops on the topic of falls and said, what are all the things, regardless of technology, that you could do to prevent falls? And have developed reports that lay out those kinds of things. So I think you're darn right. It ought to be kind of a holistic approach that says from drug therapy to behavioral change to technology-based assistance, what is the platform for preventing and detecting these things early? And I don't think the technology by itself is a part of is the only part of it. I think there's many pieces of it. The business perversities of it is a whole other difficult issue to tackle, and that's one that we struggle with in the U.S. and quite frankly is partly why we go to Europe and other parts of the world where those business perversities aren't as strong as they are here in America.
Right. Let's thank our
Great. Thank you.
speaker, Eric Fishman.
I look forward to coming back.